everybody. Thank you, ISPN and the NEfPRO program for letting me talk on this important topic. So I would be taking a physiologic approach to polyuria. I would be talking in mostly the conceptual terms, while Dr. Aditi, whose presentation comes after me, she would be discussing in new cases for which you can gain practical knowledge of the topic. So kindly pay close attention to understand core concepts of how do we approach polyuria in children. So I am Dr. Georgie. I'm an associate professor at pediatric nephrology in CMC Vellore. So how much water do you take in and how much water do you put out? So overall, in an adult, the intake from food and drink and also from metabolism comes to about 2.5 liters. And output also matches so that we are in neutral fluid balance. This also should correspond with significant solute balance because the solutes gained through food and drink should be appropriately disposed of if they are in excess or conserved if they are in deficient amount when compared to the body homeostasis. So how does the kidney? So now currently we are looking at this homeostasis of water and solutes. We are looking predominantly at the kidney. So how does the kidney produce urine? So you know that we all have an effective arterial circulating blood volume. So this blood volume has to reach the kidney and perfuse the kidneys. And when it reaches the kidneys, it is distributed into 1 million glomeruli glomeruli, which are the basic beginning part of the nephron. Through the afferent arterioles, these through the fenestrated capillary walls, this blood is actually filtered nicely into the proximal tubule, where through the process of tubular reabsorption, lot of amount of or almost 80 to 90% of all solutes and even water is reabsorbed. Most of it is reabsorbed in the proximal tubule and the distal part of the tubule, starting from the DCT, ascending limb of the loop, is where the regulation happens. So please understand the glomerular filtration is the key event or the initiating event, and the proximal tubule is the major workhorse in reabsorption of most of the solutes and water, except magnesium, which majority of it is reabsorbed in the loop of Henle. So with the tubular reabsorption, what is the important driver for the tubular reabsorption? As you know, that the kidney has a counter current multiplier system, which is built by the vasa recta, going with the blood flow going in the opposite direction. Also, the medullary tonicity gradient. I'm not going into detail about the tonicity gradient. You know that the gradient is it will be the highest at the medulla and the lowest concentration towards the cortex. So this solute and water, which reaches the distal part of the nephron, is then acted upon by an important hormone called vasopressin or arginine vasopressin or antidiuretic hormone, and after which the necessary amount of water. This is the one of the rare places where water is isolated from solutes. Normally, absorption of water always takes place along with the solutes. Actually, I should say that it's a solute what drives the water reabsorption in the other parts of the nephron, except in this part where vasopressin, by introducing aquaporin to channels into the luminal aspect of the collecting duct principal cells, increases isolated water reabsorption. So these all are important concepts to understand. So after passing through all these barriers, urine is finally formed, and the urine contains required excretory solutes, which may be very important solutes like sodium, potassium, calcium, phosphate, all the required excretory solutes. If they are not required for homeostasis management, they are excreted, and also depending on the intake of the solutes, and also appropriate amount of water is also excreted as the solvent medium in the urine. I hope this portion is quite clear to all residents. So now we directly come to the definition of polyuria. I do have some slides on physiology, which I will take in the end if it is time permits. So the range of urinary concentrating capacity varies from 50 to 1,100 or even up to 1,400 milliosmol per kg of water. So that means that kidney has to have a minimal urine output. That means if you are taking any solutes, that solute, if needs to be excreted, would be excreted if you have the solvent and the solute at the maximal renal concentrating capacity. If you divide the urinary solute load by the concentrated capacity, you will get the minimal urine output. I will put in a small calculation to show this. In a neonate whose solute osmolar load is about 12 milliosmoles per kg and has a maximum concentrated capacity of 500 milliosmoles, that means a neonatal urine 1 ml can carry a maximum of a half milliosmole of any solute. So by calculations comes, kidney has to mandatorily put out at least 1 ml per kg per hour in the homeostatic state. That means normal amount of solute load, normal kidney functions, normal renal perfusions, normal glomerular functions are available. Then the kidney, appropriate for that age, I mean. So the kidney will produce at least 1 ml per kg per hour. Hence, that is why the reason that, the definition of polyuria in units is less than 1 ml per kg per hour. If you can extrapolate this calculation to adults, adolescents, or all age group children, and if you calculate in the reverse direction, what is the maximum diluting capacity of the urine? That's about 50 to 100 milliosmoles per kg. If you look at it, you will find the upper limit of urinary output. Just wanted to show you the concentrating capacity maturation with age that increases from about 500 milliosmoles per kg and to up to 1,200, 1,400 milliosmoles per kg at 2 years when renal maturation occurs. So if you calculate this to the upper limit, it will come to actually about 2 liters per meter square body surface area, actually about 3 liters, an absolute value in adults. In smaller children, 100 to 110 mils per kg up to 2 years, and in bigger children, 40 to 50 mils per kg in older children and adults. Quantification of urine output has a prime importance in the definition and management of polyuria, which I will come to in the later slides. There are 2-3 more slides where important concepts are outlined. Functional maturity of kidney is achieved at 2 years, where the glomerular filtration at birth is from 20 to 40 in a term unit, and it comes to about 100 to 120 mils per minute per 1.73 meter body surface area at 2 years of age. So you can see that this graph nicely depicts it. And also you should know that if this kidney produces urine, there needs to be a receptacle at the other end. So that is the urinary bladder. A urinary bladder in a small child, it's usually about 7 to 10 ml per kg, and in bigger children, it can be estimated in this by this formula: age in years plus 1 into 30 in ml would be the expected bladder capacity. So you should always keep in mind when you are evaluating somebody with polyuria, you should always look at absolute total daily urine outputs, the individual urine output volumes, also as well as the frequency of urine output, and also the kidney concentrating capacity along with glomerular function. These all are important concepts. So urinary concentration principally is dependent on these 3 factors, that is vasopressin, whether vasopressin is present or vasopressin is whether present or absent. So that is the vasopressin deficiency, or vasopressin is present, however, it is unable to act at its final center, receptor, or even past the receptor area. So vasopressin problems which are AVP related can be monogenic deficiency or resistance of vasopressin, or an acquired resistance of vasopressin. Another important factor that I've already told you is the medullary tonicity or the concentration gradient. Any illness or abnormality which disturbs this concentration gradient will also result in poor urinary concentration. That means kidneys are unable to concentrate, or kidneys are excreting dilute urine in large volumes. So tubulointerstitial kidney diseases are a classical example of these. The commonest example of this happens in posterior urethral valve, hypo or hypodysplastic kidneys, nephronophthisis, autosomal dominant tubulointerstitial kidney diseases, which is a monogenic cause of TKDs. Then in lot of causes of interstitial nephritis, which are acquired, are also part of this phenomena. As I already mentioned, you should always keep in mind the glomerular function before evaluating tubular function. Then when you come to tubular function abnormalities, that is, if glomerular functions are normal, there are various monogenic as well as acquired tubulopathies which lead to excretion of large amount of dilute urine. So also please keep in mind some symptomatology and some of the definitions of when you are looking at polyuria. The frequency of micturition, anything abnormal, is usually more than 8 times during the daytime. Nocturia means child has to wake up from the night, at night to void. This is different from enuresis, which I will come to. Bladder bowel dysfunction, as you all know, it's a combined bladder and bowel disturbance. And incontinence is involuntary leakage of urine, which is classified as per the ICCS guidelines into intermittent or continuous incontinence, daytime incontinence, or enuresis. So enuresis is different from nocturia. So these is nocturia, enuresis, daytime, and the frequency of urination are all important factors when taking history of a child with suspected polyuria. Okay, so as I mentioned before, we know that there needs to be excess of either solutes or water when you have polyuria, correct? So how does polyuria happen? Polyuria happens only if there is excess of solutes which exceed the concentrating capacity of the kidney. That means even at the highest amount of concentrating capacity of the kidney is unable to exceed the solutes at a reasonable volume. Or if you look at in the other direction, there is excess amount of solute which is beyond the diluting capacity of the kidney. That is another the other physiologic cause of polyuria. So as I mentioned, excess solutes mandates a minimum amount of solvent for excretion at the maximum concentrating capacity. This phenomena is called solute diuresis, and the excess solvent which exceeds the maximum diluting capacity of the kidney, this phenomena is called water diuresis. The important causes of these are osmotically active solutes, which are maybe organic, inorganic, toxins, or diuretics. Water diuresis either could be vasopressin related, medullary tonicity related, or primary polydipsia in children. I think this slide is very important, and if there are any particular doubts on this slide, can you please ask in the chat? I will take about 10 or please look at this slide for about 20-30 seconds, because this is the fundamental understanding that you have to have before proceeding into evaluating any patient with polyuria. Okay, I hope this is very clear. So we just recap the situation. Water diuresis is excess or inappropriate free water loss with respect to serum osmolarity. So serum osmolarity or serum sodium. Before I go further, what are the components of calculating the serum osmolarity formula? If anybody can answer in the chat, just to know that you're listening and you know the basic aspects. So if anybody can answer in the chat, how is serum osmolarity calculated? Just put in the formula or the components of the formula. Can the students answer in the chat, or is that disabled? Okay, I have some information. Okay, sodium, blood urea, nitrogen, and glucose. Okay, correct. So you all are correct. So these are osmotically active substances which maintain the osmolarity of the serum, and this serum osmolarity and intravascular volume is at the maximum premium to the body, and the body wants to keep it at as normal concentration in a very tight range as much as possible. So in water diuresis, what happens is that excess or inappropriate free water loss happens with respect to serum osmolality. So hope that is clear. Normally urine osmolality is low, less than 300 milliosmol per kg, and even lesser than 100 milliosmoles per kg in the terms of diabetes insipidus. These causes, as I mentioned already, are there in the previous slide. You should know that recently, because of confusion with diabetes, there are proposed nomenclatures of central and nephrogenic DI, which are alternatively proposed to be termed as AVP deficiency and AVP resistance. Now we go into solute diuresis. So solute diuresis, what happens is large amounts of solute are excreted in the urine so that it goes beyond the concentrating capacity of the kidney. One of the contributing factors is high sodium distal delivery and the hypokalemia, which are usually associated, that can lead to secondary AVP resistance. I do have a slide on that. I hope I have time to present that slide. So okay. Also, another important concept that you need to know is called the urine osmolar load. There are 2-3 different ways to calculate the urinary osmolar load. One simple solution is 2 into urinary sodium plus potassium, because they are usually conjugated with a negative ion. Those are the prominent ions in, osmolar agents in the urine. So in non-electrolyte solutes or solute diuresis, usually it is more than 600 millimoles per day in children. Okay, I hope this part is somewhat clear. So when a child comes to us with polyuria, what do we do? So First and foremost important thing, most likely, most of you, if you are sitting in an outpatient, the parent may or may not complain of polyuria, but one thing they usually say is children have increased frequency of micturition. So increased frequency of micturition is not always equal to polyuria. The child can have small frequent voids distributed throughout the day. There are multiple conditions, classically one being polyuria, however, in which overall total daily volume is normal. So to differentiate between such conditions, it is extremely important to document polyuria with a 24-hour collection. So whenever you do a 24-hour urinary collection, you should always document concomitant creatinine measurements for adequacy. It may require catheterization in infants. In bigger children who are continent, you may use a bladder diary to look at the total intake and output. So once you have documented polyuria, then you go into the next step of evaluation. Step 2 of the evaluation, invariably clinical history and examination is part of this. So normally this is how you approach step 1 and step 2, but however, normally in clinical practice, step 1 and step 2 may be usually done in the first visit itself. So what are the salient features or clues towards diagnosis in the history and examination? Vasopressin deficiency. Vasopressin deficiency is can be predominantly usually congenital including congenital hypopituitarism, Wolfram syndrome, PCSK deficiency, etc. These can be manifested in the form of midline defects, nystagmus, optic atrophy, other hormonal involvement like growth hormone, short stature, etc. In child with a past history of head trauma or surgery, CNS infection, birth asphyxia also should be taken care to look at features of hypopituitarism. Headache or visual loss, which may suggest intracranial lesions, which may affect the hypothalamus or pituitary, can also cause vasopressin deficiency. Another rare diagnosis which can present with AVP deficiency is bone pain with the LCH, that is Langerhans cell histiocytosis, where bone pain, recurrent otitis media, and rash also can happen. Where all are the features where AVP resistance is usually seen? It can be seen in monogenic situations like X-linked AVPR2 or Coporin2 variation. These are usually infantile onset and present with large amounts of dilute urine, which usually can lead to children having significant amount of dehydration, clinical dehydration. They may even present with hypernatremia, hypernatremic seizures, intracranial calcifications, etc. It is usually a slightly difficult disease to manage. There are other forms of acquired AVP resistance, important of which I should mention are recurrent UTI, which can lead to tubular interstitial kidney disease, basic ureteric reflux disease, bladder outlet obstruction. So these features of poor stream or palpable bladder should be looked at in history and examination of if a child comes with polyuria, polydipsia. Bladder outlet obstruction may be anatomic or functional, neurogenic or non-neurogenic. Another important cause for polyuria is NEfPRO disease, which is classically a tubular interstitial kidney disease. Extrarenal manifestations which are important are reduced night vision, as in Senior-Loken syndrome. Limb or bony abnormalities are also present in NPHP. Now, psychogenic polydipsia usually presents with water diuresis without any features of nocturia. So that means they have adequate AVP. However, because of compulsive drinking during the daytime, they have to have large amount of urine volume and large amount of drinking of water. But at the night, this thing is abruptly stopped. These are usually present abruptly with adolescence or stressor being the background of this condition. Osmotic diuresis usually leads to significant extracellular volume depletion. These other features also you should keep in mind when you are looking at history and examination of a child with polyuria. Lab evaluation is one of the key factors in diagnosing the etiologies. You always have to make sure renal functions are normal with a normal blood urea and creatinine. If the renal functions are abnormal or the glomerular filtration rate is abnormal, it is imperative that the tubular functions also will be abnormal, and you should not be barking up the wrong tree when there is abnormal renal function. This may be acute or chronic kidney disease. If there is features of acute or chronic kidney disease, you should not evaluate tubular functions. Basically, tubular functions should not be evaluated at GFRs below 45 or 30 ideally. The other parameters which are important in the evaluation of polyuria is blood gas, to look at the electrolytes, blood sugar, serum calcium, and early morning urine osmolarity, which are paired with the urine specific gravity and osmolarity. You should also look at urine microscopy, urine sugar and ketones, and ultrasound may be useful in some situations, which you will come to know during the case studies. So if you do a fasting urine osmolarity with a fasting serum osmolarity, if you have high urine osmolarity, that means during the night vasopressin secretion was adequate and vasopressin acted appropriately. So if there is high fasting urine osmolarity, that essentially rules out any AVP deficiency or AVP resistance. But however, if the urine osmolarity is usually lower, very low, it is usually water diuresis. During that situation, during water diuresis, if you can look at the serum osmolarity concomitantly, that if there is hypernatremia, then usually the diagnosis of is AVP deficiency or AVP resistance. However, as you already mentioned, in the osmolarity formula, there is not only sodium, urea or blood urea nitrogen, and glycine and glucose are part of this. If the sodium is normal and osmolarity is high, you should suspect that there is uremia or hyperglycemia. So that part is clear. Very low dilute urine with concentrated serum osmolarity is diabetes insipidus, uremia, hyperglycemia. And in a way, when a water diuresis with very dilute urine, if you have concomitant low serum osmolarity, that is usually psychogenic polydipsia, that is serum osmolarity less than 280. Cases in between them, it is necessary to perform a water deprivation test, which I will come to in the next 2 slides. I hope most of the residents are familiar with the water deprivation test. It is, however, requires it's a little complex, time consuming, and requires multiple iterations for you to understand. So kindly go to your institutional water deprivation protocol to understand the intricacies of water deprivation test. I will give a brief outline in the next 2 slides. So usually water deprivation is takes place just give me a second. Sorry for the technical problem. So water deprivation test usually is done in situations of water diuresis when you have difficulty in differentiating between different etiologies of diuresis. So you have to have a serum osmolarity less than 300 with normal serum sodium, normal renal function test creatinine and urea, normal serum potassium, and blood sugar. You should know that this test is to be started in the early morning, and patients should be admitted, either short or long admission, and the duration varies from infants to older children from 4 hours to even 12 to 14 hours. You should always have your good lab backup behind when you are doing the water deprivation test. Make sure all the instruments are calibrated, and the lab should be informed that serum sodiums are being sent every hourly, and they should send reports also in time so that you can appropriately interpret the results. Normally it happens, what happens in water deprivation test is that normally when you send the first hour serum sodium, that is when usually the 0 hour serum sodium comes. So if the delays are much more than that, it is usually very difficult to keep up, and child may you may unwittingly harm the child if the lab is unable to give you results appropriately. So you should start complete food and fluid restriction and keep the patient in semi-recumbent position as much as possible. So this is the monitoring sheet for the water deprivation test. It may vary from individual units. So at the end of water deprivation test, if the targets are achieved, you can give a desmopressin challenge to see how the kidney is responding to desmopressin. Endpoints of water deprivation test. I'm not going into the detail of this in the interest of time. You can always go back to this presentation or your unit water deprivation test protocol for this. So you look at this, if you start water deprivation, usually at the lower serum osmolarity range, In a primary polydipsia, the urinary concentration achieves significantly, and even without any vasopressin. And in patients with diabetes insipidus, the urine osmolality remains constant despite significant dehydration. That means when the plasma osmolality crossed 95 or even 300, the urine osmolality is still way dilute. And if there is a response to vasopressin, that means there is deficiency of vasopressin. And if there is no response to vasopressin, it is usually AVP resistance that is happening. So please look at your own protocols for further detail. So just in a nutshell, polyuria is usually, if you confirm the polyuria, that is the first and foremost important thing in the presence of normal renal function. If you have a dilute urine, very dilute urine, that is less than 300 or 200, it is usually a water diuresis. And if you have a concentrated urine osmolality, which is around 600 milliosmol, that is usually solute diuresis. And to differentiate between intermediate situations, if the urine osmolality is between 300 to 600, you can look at the osmolar loads, and high osmolar loads are indicative of solute diuresis, while low osmolar loads are indicative of water diuresis. I know it is a little confusing. You have to go back and please read your textbooks and discuss with your seniors, which will make these very clear. Keep and another one, just 2 more slides for your or nephronothesis can present exactly like diabetes insipidus. The genetics for aquaporin 2 and AVPR are really useful in diagnosis in the current day and age. While managing a child, you should give the child free access to water. Child should have a low solute diet. Said diuretics cause sodium wasting, leading to increased proximal absorption of sodium and water, and they can manage around a 50% reduction in urine output. NSAIDs can be used to reduce EGFR. However, it does not solve the actual problem. It reduces the GFR, hence it reduces the urine output. However, it should not be used in infants or children with high risk of AKI. And these children, once they are diagnosed properly, and when they are admitted for some illness which has fluid losses, that is pneumonia, diarrhea, any of these which can cause sensible or insensible water losses, you should remember that unless in clinically hypovolemic or in shock, you do not use isotonic fluids. Why? Because the kidneys have temporarily or permanently lost the ability to concentrate fluids. If you give an osmolar load, the kidney will not be able to control the water content in the urine, and they will perpetuate the fluid losses. So these patients should have hypotonic fluid replacement for maintenance therapy. I would not be going into the physiology of this. Just keep in mind that aquaporins are distributed throughout the nephron. Aquaporin 1 in the proximal tubule, urinary transporters, which are important for medullary tonicity, UTA1, UTA2, UTA3, and aquaporin 1, aquaporin 7 is also there. Aquaporin 2, 3, and 4 are present in the collecting duct and the distal tubules. So this is the mechanism of action of aquaporin. Aquaporin binds to AVPR2, and by the downstream action by the CAMP and protein kinase A pathway, it inserts the aquaporin 2 from the endocytic vacuole vesicle into the luminal surface, where fluid is reabsorbed. These are secondary causes of nephrogenic DI: hypercalcemia, hypercalciuria, and hypokalemia. Are important cause of secondary nephrogenic DI when you should keep in mind when you are doing the diagnosis. This is the physiological basis behind this. I'm sorry, I will not be able to go into detail on this because of lack of time. Important take-home points in evaluating any patient with polyuria is, first and foremost, you should know that urine volume at any age group is an important function of combined function of glomerular function, tubular maturity, and water or fluid or solute intake in a patient. Urine volume measurement is very vital to the diagnosis. Usually, patients with polyuria, it is not extremely difficult to make a broad diagnosis. However, to find the exact etiology may be a little difficult. If you do a thorough history and examination, you usually end up with a good clinical diagnosis and a reasonable laboratory diagnosis even before you go into detailed examination. Urine osmolality and serum sodium are the key parameters in evaluating any patient with polyuria. So you should keep in mind that when you are evaluating a patient with polyuria, renal functions are normal. If renal functions are normal, glomerular functions are normal, are you looking at a water diuresis? Are you looking at a solute diuresis? Then it becomes easier to dissect into the etiologies and find the appropriate etiology and management of these children. With this, I stop my presentation. Thank you.
Thank you, Dr. Georgie. It was a very clear presentation of the problem polyuria. I think there yes.
Dr. Aditi, are you able to share your slides?
Yes, ma'am, I'll just share. Good evening, everyone. Are the slides visible?
Yeah, just go full screen, Aditi.
Yes, ma'am. Good evening, everyone. Apologies on behalf of Dr. Puneet. He was supposed to present the cases, but some last minute issues is not there. So I'll be discussing the cases. Should I start, ma'am?
Yeah, go ahead.
Yes. So our first case is a 5-month-old boy who presented to us with symptom onset at around 4 months of age. The chief complaints were poor weight gain and frequent urination, which was in excess amount as noticed by the parents. He was born by spontaneous vaginal delivery since the onset of symptoms were at 4 months of age at early infancy. So we looked at the perinatal or the antenatal history, which was all normal. There was no history of any polyhydramnios, normal vaginal delivery with a normal birth weight. So his symptoms onset were at 4 months of age, and he presented to us a month later, that is at 5 months. And chief complaints were failure to gain weight and passing large quantity of urine. Obviously, then the parents' mother complained of irritability in the infant, and there was frequent demand for feeds. So there was no history of any altered sensorium or abnormal movements indicating any central nervous system involvement or any precordial activity, bluish discoloration, suggestive of any cardiac involvement or any rapid breathing, chest retractions for any respiratory involvement. There was no abdominal symptoms. All these, this negative history was taken to rule out any chronic illness which was leading to failure to gain weight. There was no history of any floppiness or or constipation to indicate that there was any major electrolyte loss. Chiefly, we are looking at potassium here. There was no history of any repeated fevers because history of increased passage of urine is associated in infancy with dehydration fevers, because an infant is not able to cope up with the increased demands. They always remain thirsty. And there was no history of any crankiness or crying while passage of urine or poor urinary stream, which was seen to rule out any recurrent UTIs or obstructive uropathy. The child was on exclusive breastfeeds. There were no top feeds. So hypoosmolar feeds were given, and there was no history of any visual or hearing impairment in the child as per mother. The child at 5 months of age was fairly preserved as far as developmental domain was concerned, and his developmental age was at around 4 months at chronological age of 5 months. So current issue was that he was admitted in some other hospital with recent history of fever for 3 days with loose stools, 5 to 6 episodes, watery but no blood in stools, and there was no history suggestive of any UTI, or there was no history of suggestive of any respiratory cause of fever. And investigation outside were done, probably keeping sepsis as the first differential in a infant with the high-grade fever. And we just reviewed the investigation, and what we could see was there was a value of 3 of potassium, which was borderline low, and the blood gas done there was suggestive of metabolic acidosis. So a 5-month-old infant with a history of frequent passage of urine and frequent demands of feed with a recent history of loose stool and fever was admitted with us. His anthropometry suggested that he was stunted. Otherwise, vitals were stable and blood pressures were within normal limits. There was the general physical examination was absolutely normal. There was no dysmorphism. There was no evidence of rickets. There were no signs of dehydration as the infant had presented with loose stools, but no dehydration was there. Even the systemic examination, including the genitalia, was absolutely unremarkable. So just to recapitulate, a 5-month-old firstborn male infant with no significant antenatal or perinatal history, chief complaints were failure to gain weight and passage of excessive urine. So keeping this history in mind, the differentials which we thought was in renal tubular acidosis in view of increased frequency of micturition and failure to thrive, tubulopathies such as Bartter syndrome, history of increased passage of urine could be due to diabetes insipidus per se, and of course, as Dr. Georgie discussed, that in infancy, tubulointerstitial diseases may lead to increased passage of urine. So chronic kidney disease leading to failure to thrive was also kept as a possibility. So with these possibilities, we evaluated the infant, and the routine hemogram was okay. It was also done to rule out sepsis, but nothing was forthcoming. Important to note that GFR was preserved, so a chronic kidney disease was ruled out at this stage. His electrolytes continued showing borderline hypokalemia with potassiums of 3.2, 3.1. Striking thing to note was the metabolic acidosis with blood pH of around 7.29 with normal PCO2s, but by lower bicarb of 12.3 or 15.1 at 2 different occasions, suggesting of metabolic acidosis. And the electrolytes, again, the VBG electrolytes showed hypokalemia. The anion gap was normal, and blood sugar, magnesium, and all the other electrolytes were within normal range. So what we have from here is an infant with a normal GFR showing hypokalemia with metabolic acidosis on blood gas, a normal anion gap metabolic acidosis on blood gas. So considering renal tubular acidosis as one of our differentials in view of metabolic acidosis, not in a setting of sepsis, we went ahead doing a bicarbonate loading test, which is a typical test which is done in order to demonstrate whether it's a proximal or a distal RTA. So in bicarbonate loading test, we kept giving bicarbonate IV to the infant till the urine pH was around 8 and blood pH rose to around 7.4 and bicarb was normalized to around 25. So at these values, the urinary to blood carbon dioxide gradient was very low. It was 12 millimeters of mercury, whereas it should be around 20 in a normal person. Because we are giving a bicarb load, in case the distal tubules are not at fault, there is an increased production of H positive ions, which forms carbon dioxide and which leads to an increased urinary to blood carbon dioxide gradient. But here, despite giving bicarbonate, the urinary to blood carbon dioxide gradient was low. It should be ideally less than 10, but even 12 was considered as low, indicating a distal acidification defect. Also on bicarb loading, when we did a fractional excretion of bicarb, it came out to be within normal range. So less than 5% is normal, and our child had a normal fractional excretion of bicarb. Whereas in a proximal renal tubular acidosis, where reabsorption of bicarb is not being done and whole of the bicarb is secreted in the urine, if you give a bicarb loading, the excretion crosses 15 to 20%. So this a bicarb fractional excretion of less than 5% was also normal and was in favor of a distal renal tubular acidosis in the background of an infant having failure to thrive, having increased urinary output, and having hypokalemia and metabolic acidosis on a blood gas. So ultrasound of the kidneys showed bilateral medullary nephrocalcinosis. Going back to the increased urinary production, the 24 hours urinary amount was documented, and the baby was producing around 500 milliliters of urine per day, which came to around borderline polyuria. It comes to around, say, 50 ml per kg per day, which qualifies for polyuria in an infant. And this 24-hour value was adequate. The collection was adequate because the creatinine was at around 13 milligram per kg per day. So because of medullary nephrocalcinosis, the 24 hours calcium excretion was at 4.8 milligram per kg per day, which was high. Anything above 4 is taken as high. And even the calcium creatinine ratio was 0.3, which is high. We did this 24 hours urine collection sample for other solutes also, because the baby was excreting calcium in the urine, leading to hypercalciuria, leading to medullary nephrocalcinosis. However, rest of the solutes were normal. Particular attention to the low molecular weight proteins like beta-2 microglobulins and other which the excretion was normal. Now, in a case of typical tubulopathy, there is massive solute loss in the urine. And how we differentiate a proximal tubulopathy versus a distal tubulopathy is a proximal RTA is a kind of a global RTA where not only solutes but amino acids, low molecular weight proteins, they are also lost in urine. But an isolated loss of certain elements such as calcium and potassium and sodium, it goes more in favor of a distal RTA where low molecular weight proteins and amino acids are not being lost. So a very important fact that beta-2 microglobulin was normal. So our patient was, again, the 24 hours urine was going in the favor of a distal tubular defect. So we had a 5-month-old boy, just to recapitulate, with failure to gain weight, passage of excessive urine, where we have established that he has polyuria. He had a normal anion gap metabolic acidosis with hypokalemia, a low urinary to blood carbon dioxide gradient, and a normal bicarbonate fractional excretion after a bicarb loading test. And the ultrasound showed bilateral dense nephrocalcinosis, and there was hypercalciuria. So with all these positive findings in a 5-month-old boy, we home down to the diagnosis of a distal renal tubular acidosis. Then we did a targeted genetic testing. A clinical exome was sent, and a defect in ATP6V1B1 gene was found, which was homozygous, and it fits into an autosomal recessive form of distal RTA. This kind of mutation is associated with early deafness in infancy. However, in our infant at 5 months of age, the hearing was normal. So our diagnosis was distal renal tubular acidosis with the mutation in this gene. Eye assessment in view of RTA was done. So there were no cystine crystals. It was normal, and even hearing was normal. So for his acidosis and hypokalemia, the child was started on bicarbonate and potassium supplementation, and it was given in the form of syrup urilizer, which would help in hypercalciuria also. So this was one clinical scenario where an infant presented with polyuria with some tubulopathy, which fits into a secondary form of nephrogenic diabetes insipidus, that is distal RTA. So should I move on to the next case or any queries?
Aditi, you have to finish quickly, so please keep moving on.
Okay,
There's no
fine,
time. We're running short of time.
Right, ma'am. So next we had a 1.5-year-old boy. So he presented at very even earlier, at around 1.5 months of age, with poor weight gain and height, and again passage of excessive urine. So there was failure to gain weight, excessive amount of urine. He also had history of passing urine several times during night. So this is one thing in a 1.5-year-old child, when there's history of passing urine during night, it rules out psychogenic polydipsia, because though it's seen in a bit older children, but the typical history of passing urine at night suggests that there's something pathological, and there was preference for salty foods. Again, there was no history of any systemic involvement which had led to failure to thrive, and there was no history of obstructed uropathy, any bony deformities, or hearing difficulty. In this baby, there was a significant perinatal history, in the sense that he was born preterm with a low birth weight, and there was antenatal history of polyhydramnios. And also in the previous pregnancies, the mother, there was history of polyhydramnios. However, there were one was a preterm delivery who died, and another was a almost near term, early term delivery who died. So the history of polyhydramnios was very particular. Now this child at 1.5 years of age had severe stunting and wasting. Vitals were stable, and blood pressure was also fine. There was no dysmorphism per se, no evidence of cataract or any rickets, and all the systemic examination was normal. So the possibilities in a preterm birth with history of polyhydramnios, with history of increased passage of urine and failure to thrive, a possibility of Bartter syndrome was kept high, and then a renal tubular acidosis. And the last three differentials we've already discussed would be same as that it was in the previous case. So his hemogram was normal, and electrolytes did show hypokalemia, and the blood gas was suggestive of metabolic alkalosis. So here we have a case of hypokalemia with metabolic alkalosis. Urine volume, which is the first step in determining whether it's polyuria or not. So urine output was at 7.8 ml per kg per hour, which is definitely, he was quite polyuric. And also 24-hour calcium excretion was also quite high. And corroborating with it, the ultrasound showed medullary nephrocalcinosis. His hearing evaluation was normal. So with a query of RTA or Bartter syndrome, and because of antenatal polyhydramnios, prematurity, low birth weight, polyuria, metabolic alkalosis with hypocalcemia, and nephrocalcinosis, we sent a clinical exome to diagnose Bartter syndrome, and we had a mutation in SLC1-2A1 gene. Again, it was pathogenic, homozygous mutation in this case. Now this child was started on potassium supplements, and since he had significant amount of polyuria, he had to be started on indomethacin also just to tide over the polyuria part of it. The last case is a slightly older child. Now, this child also has excessive crying for feeds and frequent urination. So more or less the complaints of all the 3 cases have started in infancy, and how they've evolved is a bit different. So this child, who is currently 3.5 years old, had excessive crying for feeds and frequent urination noticed since 3 months of age. His antenatal and perinatal history was absolutely normal, and he was developmentally normal. The symptoms which were noticed at 3 months of age were typically excessive crying, used to get relieved after crying, passage of excessive amount of urine, and the mother characteristically noticed that there were, diapers were really heavy with urine when he was an infant. And presently also, at around 3.5 years of age, he's passing large quantity of urine, around 12 to 15 times per day. There was also a history of undocumented, but history of fever and excessive thirst. All the relevant negative history was taken, and nothing was contributory. He was, anthropometry was absolutely normal, and normal blood pressures. The systemic examination was also unremarkable. So now we have a slightly bigger child who has passage of large amount of urine, but history of intermittent fever and excessive thirst, and there's no history of any floppiness or developmental delay with an essentially normal physical examination. So the possibilities here also remain the same, but since there's no failure to thrive, so renal tubular acidosis and the tubulopathies come lower in our differentials. So we have kept diabetes insipidus per se as the first differential, and thereafter, obviously, rest, we'll see how it evolves on investigations. So hemogram was completely normal, and the electrolytes were also normal. There was no metabolic alkalosis or acidosis. He had a normal GFR. So coming to polyuria per se, so 24 hours urinary volume was around 8 to more than 8 liter per meter square per day, which qualifies for polyuria. Since there was no other biochemical abnormality, we did a urine osmolality, which was pretty low. So that was 48 milliosmoles with an almost normal serum osmolality. Ultrasound kidneys was normal at this stage. Now, with a low urine osmolality at a normal serum osmolality and normal electrolytes, we went ahead for a water deprivation test. So this was how it was conducted. This is the time frame, the weight of the patient, the vitals, the urine osmolality, serum osmolality. And to note is that we had also taken one control just to, be sure of the lab values. So this was the control. Generally, it is one of the parents. So we started where vitals were stable, serum osmolality was normal, serum sodiums were normal. This is one of the prerequisites of a water deprivation test. And serial monitoring of urine osmolality, we found that urine did get concentrated, but it still remained below serum osmolality. And there was a weight loss of not less than of around, say, less than 4%, and vitals were stable. Vitals were all throughout stable. So one of the indication or one of the time points where we terminate a water deprivation is if there is any evidence of hemodynamic instability like hypotension, tachycardia, or if there is a weight loss of more than 5%. So here, none of the factors were there, but then what we found was that urine osmolality in 6th, 7th, and the 8th hour was almost it had almost plateaued. There was no further increase in the urine osmolality. So this was one reason of almost, terminating it at this point. However, at this point, still it was not concentrated. So we give a vasopressin challenge. So we injected vasopressin, and the subsequent urine osmolarities, there was an increase almost of more than 50% from the prior, with serum osmolarities remaining normal. So this kind of patient where there is a clinical and biochemical evidence of diabetes insipidus, and water deprivation test has not led to the expected increase in the urine osmolality. However, after vasopressin, there is a significant increase of more than this thing in the urine osmolality. Response to the vasopressin challenge. So we diagnosed him as a case of partial central diabetes insipidus. In this case, the child was started on tablet desmopressin twice daily, and we saw the response in this in the form of normalizing of the urine osmolality and decrease in the amount of polyuria. So these were the three different cases where it was an approach to polyuria in an infancy and in a slightly older child. Generally, it is the clinical scenario. It might not come as a standalone polyuria in a patient. Generally, in an early infancy, they come with associated biochemical abnormalities like metabolic acidosis or alkalosis, along with hypokalemia, or in a slightly older child where there are no electrolyte abnormalities and there's no acidosis or alkalosis, then we have to delineate whether it's a central or a nephrogenic diabetes insipidus or a psychogenic polydipsia. So water deprivation test, as Dr. Georgie discussed, is the mainstay of differentiating these kind of polyuria syndromes.
Thank you very much, Aditi, for illustrating very well illustrated cases. They've, I think, clarified what Georgie started out with. So I think it's time to end the session also. So I'll hand over to Dr. Jitendra. Are we?
Thank you, Dr.
Can we carry on with some
Yes.
questions, or can we take some questions from the chat, or are we done? I think Georgie's
First
answered
we'll
some.
have the post-test.
Okay.
Yeah.
Because we answered most of the questions in the chat, I think.